Hello everyone. In the last recording we talked about hemoglobin oxygen dissociation curve, and we talked about the effect of temperature and pH and 2 and 3 DPG or BPG on that curve. Now let's talk about hemoglobin F. As you remember, hemoglobin F is a hemoglobin that you find in a fetus. The structure of hemoglobin F is alpha 1, alpha 2, gamma 1, gamma 2. We know that hemoglobin F has a very high affinity for oxygen. Now think about it. If this is placenta, here is the mom's blood, and this is the fetus blood. The oxygen is going to come from the mom, is going to come to the placenta, and blood is going to move away, but the oxygen is going to come to the fetus. But why oxygen is going to come from mom to the fetus? What's the reason? Well, because fetus is carrying hemoglobin F, but mom is carrying hemoglobin A for adults. When the blood comes to the placenta with oxygen, oxygen is going to ask itself, should I go to hemoglobin F or should I stay with hemoglobin A? Well, hemoglobin F has a very high affinity for oxygen. Oxygen prefers to go to hemoglobin F than staying with hemoglobin A. That's why oxygen is going to move to the fetus. But why is that? One of the reasons that hemoglobin F has a high affinity for oxygen is hemoglobin F doesn't have beta chain. As a result, DPG or BPG cannot attach to hemoglobin F. Remember, when DPG attaches to hemoglobin A, it's going to let the oxygen go. Since hemoglobin F doesn't have beta chain, cannot attach to DPG, and as a result, the affinity for hemoglobin would be higher. Now, that is going to bring us to the transport of CO2. The CO2 can be transported in three ways. The first one is in the form of dissolved in the blood. Remember, CO2 is a very soluble gas. 5% of the CO2 is dissolved in the blood. Another 5% is going to be carried by hemoglobin. Remember, hemoglobin can carry oxygen, but also hemoglobin can carry CO2. It's not the same site that oxygen sits. CO2 is going to attach to NH2 group of the protein instead of attaching to the iron. So as you can see, there are two different sites. One is the iron that attaches to oxygen, another one is NH2 amino group of protein that attaches to the CO2. And the rest of them, which is 90%, would be in the form of HCO3. CO2 can combine with water to create H2CO3, thanks to an enzyme is called carbonic anhydrase. H2CO3 is going to break down to H and HCO3. So as a result, my CO2, in a sense, can be carried by bicarbonate. Again, the enzyme here is carbonic anhydrase. Can we create H2CO3 without using this enzyme? The answer is yes, we can, but that process will be, of course, very slow. In this picture, you can see when the tissue creates CO2, CO2 can be dissolved in the plasma. This picture of your book says 10%, but I think 5% would be more appropriate, so please memorize it as 5%. In this book, it says 20% is going to attach to hemoglobin. Again, please realize it's 5%. And finally, we have 90% that is going to be in the form of bicarbonate. So please change this percentage to 90%, 5%, and 5%. CO2 is going to add to the water, is going to create carbonic acid. Carbonic acid is going to break down to H and HCO3. HCO3 is going to leave the RBC. Remember, this is going to happen inside the RBC. HCO3 is going to leave the RBC, is going to come to the plasma. Now, when the HCO3 comes to the plasma, then plasma is going to have more anion. To keep the number of the negative charges inside the blood, I have to bring a negative charge inside the RBC. As a result, when HCO3 is going to come out, chloride is going to come inside the RBC. This is called a chloride shift because chloride is going to move inside the cell to balance the number of the negative ions inside the blood. And then this hydrogen is going to attach to hemoglobin to become neutralized. When this blood reaches the lung, everything is going to get reversed. In other words, CO2 that is dissolved is going to come inside the alveolus and you can expire it. The CO2 that is attached to hemoglobin in the form of carbaminohemoglobin is going to get released and is going to come to the alveolus. And everything that you saw in the previous picture is going to get reversed. In other words, the HCO3 is going to come to the RBC, Cl is going to get out, HCO3 is going to combine H to create H2CO3, and H2CO3 is going to break down to water and CO2. Again, the enzyme is carbonic anhydrase. So carbonic anhydrase can create H2CO3 or can break it down to water and CO2. And CO2 is going to get exhausted inside the alveolus. Let's talk about how we're going to regulate pulmonary blood flow. The pulmonary blood flow can be regulated by constriction or opening of the arteriole, like any other places in the body. But what causes the arteriole to close off or open up? The main player to change the size of arteriole in the pulmonary blood flow would be oxygen. PaO2 is a major factor. If the PaO2 drops, it's going to cause vasoconstriction. If the PaO2 goes up, it's going to open up the arteriole. This is opposite of what you know about other arterioles. In other arterioles, when PaO2 goes down, the vessel is going to open up to bring more blood. In the lung, the story is different. You may ask me why. Now think about it. If this is the lung, and this is the airway that brings the air in, if this air is going to come, let's say, to this area, to this alveolus, and if this alveolus doesn't get oxygen, if this one is for some reason is blocked, and PaO2 here goes down, what is the purpose of bringing blood here? Don't you think if I bring blood here, that is going to be a waste of my blood because there's no oxygen? So in the lung, as opposed to any other organ, if the PaO2 goes down, it's going to create vasoconstriction, because if there is no air, if there is no oxygen, there is no need to bring blood here to waste this blood. So therefore, in the case of pulmonary blood flow, decrease in PaO2 is going to cause vasoconstriction. If the PaO2 goes below 70 millimeters of mercury, you're going to have vasoconstriction. This is important because that's the reason that blood doesn't go to the fetus. Now think about it. We know that fetus lung does not function. When the fetus is inside the uterus, there is no need for the lung of the fetus to function. So therefore, there is no oxygenation happens inside the lung. Since the PaO2 inside the lung of the fetus is so low, what do you expect? That means the blood vessels inside the lung of the fetus is collapsed. There is no oxygen, there is no need for blood circulation. That's the reason that blood of the fetus doesn't get to the lung, because when the lung doesn't get oxygen, then the blood vessels that is going to the lung is going to also collapse. Because of that, only 15% of the blood is going to get to the lung and is going to get out. Obviously, there's not going to be any oxygenation. Is oxygen the only factor that controls the size of arteriole? The answer is no. There are other players. There are all other vasoactive substances like thromboxane A2, like prostaglandin I2, or like leukotrienes. You remember thromboxane A2 is a vasoconstrictor. Thromboxane A2 can be released from the lung tissue in a specific type of lung injuries. Some injuries that are going to make your lung to produce thromboxane A2, and as a result of that one, thromboxane A2 is going to cause vasoconstriction of both arteriole and veins. Prostaglandin I2 is called prostacyclin, on the other hand, is going to cause vasodilation, as you remember. Prostaglandin I2 is released by lung endothelial cell. And finally, leukotrienes are the one that cause vasoconstriction, but also they do constriction of the airway. Do you remember leukotrienes? Here is your leukotrienes. We said before that arachidonic acid can create prostaglandin, but arachidonic acid also can create leukotrienes. Now, let's take a look at this picture. This is a lung. We're going to divide lung in 3 zones. Zone 1, Zone 2, Zone 3. Zone 1 is through the apex, the tip of the lung. Zone 3 through the base of the lung. We already said that because of the gravity, there are more blood flow in the Zone 3 and less blood flow in Zone 1. You already know this one. So that's why you can show us blood flow here is the highest and blood flow here is the lowest. Of course, here's a medium. Pressure of air. We are not talking about pressure of oxygen. We are talking about pressure of air inside the alveoli. The pressure of air inside the apex is higher than the pressure of air inside the Zone 3. PA shows the pressure of air inside the alveolus, and PA shows the pressure of air inside the artery. We said blood flow here is low, so therefore pressure of the blood here is going to be low. But pressure of air here is high, so PA here for pressure of air is higher than pressure of the blood. In here, we said there's more blood flow, therefore pressure of the blood flow is higher and pressure of the air is much lower. We also need to consider alveolar ventilation, the amount of exchange of gas in and out of alveolus. In the clinic, we use something is called VQ. It's called ventilation perfusion fraction. V is for ventilation, and Q is blood flow. Now I want you to follow me through. In average, when I look at the whole lung, the VQ, this ventilation perfusion fraction, is about 0.8. That means 80 over 100. That means my perfusion around 20% more than my ventilation overall. But in each area of the lung is different. In zone 1 is around 3. In other words, we have 300 over 100. That means my ventilation is 3 times more than my perfusion. That's zone 1. In zone 3, however, is around 0.6. That means my ventilation is, let's say, 60 and my perfusion is 100. That means my perfusion is better than my ventilation. So in average, in the total lung is about 0.8, but it doesn't mean everywhere is 0.8. In the zone 1, toward apex, you have a better ventilation. In the zone 3, we have a better perfusion, but not a very good ventilation. And that is going to bring us to the very last part of this discussion. We're going to talk about how we're going to breathe, what controls our breathing. To understand how breathing works, you have to know a couple of things. One is, remember your diaphragm is like a dome shape. Here is your abdomen, and here's your thorax. This is supposed to be your lung sitting here, right? And heart is going to sit right here. When you want to breathe in, your diaphragm is going to contract and it's going to come down. It's going to become like this. When you relax your diaphragm is going to go back up. So right now in this picture, it shows diaphragm is relaxed. When diaphragm is going to contract, it will become a straight line. This one is going to come down and becomes straight. This is when it's contract. So that's the first thing you have to know. The second thing that you have to know is, here is a blood-brain barrier. It's a barrier between your blood and your brain. Specifically, we are dealing with medulla here. Medulla has 2 centers. One is called dorsal group. Let's say this is dorsal group. And then we have another one is called ventral group. This is my ventral group. So there are 2 groups inside the medulla that control my breathing. So here's how it works. When the CO2 inside the blood goes up, this CO2 can pass through blood-brain barrier. CO2 is going to join water and create, as you know, H2CO3. H2CO3 is going to break down to bicarbonate and H. This is the H that can stimulate dorsal group. When the dorsal group is stimulated because of H, it's going to send impulse through phrenic nerve to the diaphragm, and that is going to go to contraction. As a result, you can breathe in. So what makes you to breathe in? When the CO2 goes up. When CO2 goes up, it's going to increase H inside the medulla, and that is going to stimulate dorsal group. Dorsal group is going to send information through phrenic nerve, contract diaphragm. Diaphragm is going to come down. As a result, you breathe. For expiration, however, you don't need to do anything, because remember, your diaphragm is like a dome shape. When you contract it, it's going to come down like this. If you don't do anything, it's going to relax and it's going to go back up. So therefore, we say inspiration is active, but expiration is passive. Because for expiration, you don't need to do anything. As long as you don't do anything with this diaphragm is going to relax. And it's going to relax, it's going to push up, and it's going to make you to lose air. Now, what's the function of ventral group? The ventral group is for deep expiration. When you're exercising, you have to expire deeply. That means you have to push this air out forcefully. So diaphragm by itself is not enough. I have to use my other muscles to force this air out. So ventral group is for deep expiration. Besides medulla, we have a couple of centers in the pons which also controls breathing. Let's take a look. In this picture, you can see this is the pons and this is medulla. As you can see in the medulla, we have 2 centers. One is called dorsal group and another one is ventral group. In the pons, we also have 2 groups. One is called pneumotaxic area and is called apnostic area. Apnostic area is going to prolong your inspiration. So you're going to go like this. You're going to breathe in longer and your expiration is going to get short. That type of breathing that I just mimicked is called apnostic breathing. Apnostic breathing is abnormal breathing, and that is because of stimulation of this apnostic center. On the other hand, pneumotaxic area, this one is going to do reverse. It's going to make your inspiration pretty short as half a second. And I'm sure you realize when your inspiration gets very short, your respiratory rate is going to go up, so you're going to breathe faster. So that is going to increase your respiratory rate up to 40 times per minute. Now, besides the center that we have inside the brain, we have some centers in the peripheral that also can control our breathing. Those are called peripheral chemoreceptor. Those peripheral chemoreceptors are located at carotid body by bifurcation of this carotid artery, and also in the aorta. It's called aortic body, carotid body. These two centers, they can control three things. One, they respond to low oxygen. Remember, the normal pressure of oxygen is about 100, 95 to 100. If the pressure of oxygen goes below 60, then this carotid body and aortic body become agitated, and they're going to send signal to the medulla, to the dorsal group, and tell the dorsal group, hey, what's happening here? Why don't you make diaphragm to work? So carotid body is going to send information to medulla through cranial nerve number 9, and aortic body is going to send this information to the medulla through the cranial nerve number 10. And they're going to make medulla, the dorsal group of medulla, to become more active. And we said the threshold is 60 millimeters of mercury. The second one is CO2. Increase in CO2 is going to activate only carotid body but not aortic body. CO2, when it goes up, is going to stimulate carotid body. Aortic body has no receptor for CO2, but carotid body has. However, this receptor is so weak. In other words, carotid body does not care that much about CO2. The most important drive here would be low oxygen. But the third receptor that you find in carotid body or aortic body would be pH receptor. It's going to respond to the pH. When the pH goes down, that is going to stimulate these receptors. This has nothing to do with the CO2. For any reason, if the pH in your blood goes down, those two centers are going to become agitated. For instance, if someone is diabetic, and because someone is diabetic, is going to create lots of acid in the blood, and that is going to stimulate this carotid body and aortic body. This decrease of pH is unrelated to the CO2. Anything that brings your pH down is going to stimulate these two centers. Besides these two receptors in the medulla or in the peripheral, we have other receptors. For instance, we have receptors inside the lung. When your lung is going to get stretched, that is going to when your lung is going to get distended, that is going to start a reflex, and that is going to increase your expiratory time. So it's going to make you to expire more and decrease your respiratory rate. So you're going to breathe deeply but slowly. So that's another receptor. The second receptor that we have is in joint. As soon as you start running and doing exercise, there are receptors in the joint and muscle that they're going to send impulse to the brain even before your muscle needs more oxygen, but your brain knows that your muscles start doing exercise and I have to adjust the breathing rate. With the same token, we have some receptors, it's called irritant receptor. These receptors, they are located between epithelial cells of the airway and respond to the particle or chemical that stimulates or irritate your airways. By stimulation of these receptors, they're going to constrict your bronchial system, and as a result, your breathing rate should increase. That's why you're going to have, in the case of, let's say, asthma, you have constricted airways. And finally, we have a receptor, it's called juxtacapillary receptor, it's called J receptor. They are located in the wall of the alveolus, close to the capillary. And when the capillary gets engorged with blood, if the blood is going to come inside the capillary surrounding the alveolus and stay there for a longer time, these receptors become activated, that make you to breathe fast but shallow. And also, if they become stimulated longer, they're going to create coughing, and patient is going to feel dyspnea, which is difficulty in breathing. And that is going to bring us to the end of this chapter. I hope you enjoyed it.